Have you ever stopped to think about those medications? You know, the ones that seem to do a little bit of everything, popping up in unexpected places?
Hmm.
Today, we're doing a deep dive into exactly that kind of drug, tricyclic antidepressants, TCAs.
Right.
Our mission here is really to unpack what TCAs are, how they work at a fundamental level in the brain, their, well, surprisingly broad uses beyond just depression, and crucially, what you really need to know about their effects and interactions.
Yeah, it's fascinating, isn't it, how these um, often seen as older drugs,
Mhm.
primarily for mood,
Right.
actually have such complex and, well, far-reaching effects in the body. Their versatility genuinely surprises a lot of people.
That sets us up perfectly. So let's start right at the basics. What exactly are tricyclic antidepressants and how do they start influencing our brain chemistry?
Okay, so TCAs are a specific class of drugs. This includes different types, like amines, secondary amines, and also tetracyclics. Now, their core action, the main thing they do, is reduce the reuptake of two key neurotransmitters.
Okay. Which ones?
Serotonin, we often just call it 5-HT, and norepinephrine, or NE. They reduce the reuptake back into the nerve cells.
So if they're reducing reuptake, does that mean these neurotransmitters just sort of hang around longer in the space between nerves?
Exactly. You got it. That inhibition means 5-HT and NE buildup, they accumulate in the synaptic cleft. That's that tiny gap between nerve cells.
Right, the synapse.
Precisely. And because they're there longer, they increase the stimulation of the postsynaptic receptors, the receiving end on the next nerve cell. This whole mechanism ties directly into the biogenic amine theory of depression.
Which says depression might be linked to low levels of these amines.
That's the idea, yeah. The theory posits a deficiency, and TCAs are thought to help by boosting those levels right where it counts in that synaptic space.
It's amazing how tiny chemical changes there can impact moods so much. So, if they all work this way, are they basically interchangeable? Or does the specific TCA matter?
That's a great question. While generally speaking, all TCAs are similarly effective for depression, the actual choice often comes down to the individual, how someone responds, and critically, how well they tolerate the side effects.
Ah, tolerance.
Yeah. And what's really interesting is that a patient might not respond to one TCA, but they could respond well to a different one, even from the same class. It really highlights how individual biochemistry varies.
Any common examples people might recognize?
Sure. Some common ones are amitriptyline, imipramine, which you might know as tofranil nortriptyline or Pamela, and clomipramine, often known as anafranil.
Right, okay. That individual response point is key. Now let's get into the really interesting part because TCAs are used for way more than just depression, aren't they? What are some of these surprising uses?
Well, their main job, their primary indication, is definitely relieving depression symptoms. And like you hinted, their sedative effects can be quite helpful, especially for patients whose depression comes with a lot of anxiety or trouble sleeping.
But I've heard them described almost like a, I don't know, a Swiss Army knife used for things that seem totally unrelated, like pain.
That's a good analogy.
Yeah.
It's true. Their use in areas like chronic pain or even childhood enuresis that's bedwetting in kids over 6 is fascinating.
How does that even work? How does an antidepressant help with bedwetting or pain?
It highlights how connected our nervous system is, beyond just mood circuits. Their effectiveness in chronic, intractable pain, things like neuropathy or fibromyalgia, it's not just a side benefit. It's linked to how they modulate nerve signals more broadly. And remember we mentioned they affect neurotransmitters. They also have significant anticholinergic property.
Anticholinergic,
Yeah,
meaning they block acetylcholine.
exactly. Acetylcholine is involved in loads of things, muscle contractions, memory, gland secretions. By blocking it, TCAs have these other effects. And these aren't just side effects. Sometimes they're part of why they work for these other conditions.
Like the pain or maybe even anxiety.
Yes, definitely anxiety disorders too. And clomipramine, one we mentioned, is specifically approved for obsessive compulsive disorders, OCDs. So it's this multifaceted action hitting serotonin, norepinephrine, and acetylcholine receptors that give them such diverse uses.
So those anticholinergic effects, they're not just nuisances, they're part of the toolkit. That really explains the versatility. Okay, given how powerful and wide-ranging these are, how do they actually move through the body? What's that journey like?
Well, they're generally absorbed pretty well from the GI tract. They usually reach peak levels in your blood relatively quickly, typically within, say, 2 to 4 hours.
Okay, so they get in quickly, and then where do they go? How long do they stick around?
Good question. They bind strongly to proteins in the blood, and they're quite lipid-soluble, meaning they like fatty tissues. This lets them distribute widely throughout the body, including, importantly, the brain.
Makes sense.
The liver is where they get metabolized, broken down, and then they're excreted mostly in the urine by the kidneys. A really key feature, though, is their relatively long half-lives.
Half-life meaning how long it takes for half the drug to leave the system.
Exactly. And for TCAs, this can range quite a bit, from maybe 8 hours up to, wow, 46 hours for some. That means they stay active in your system for a good while.
Okay, so they linger. Now, if someone starts taking a TCA today, when do they actually start feeling better? That long half-life doesn't necessarily mean instant relief, right?
Absolutely not. And this is such a crucial point clinically. While the drug gets into your system quickly, it can easily take 10 to 14 days, maybe even 2 weeks, just to see the initial therapeutic effect.
2 weeks just to start.
Yeah. And the maximum benefits, those might not be seen for 4 to 8 weeks. Think about that.
Wow.
If you're dealing with severe depression, starting a medication and being told you might not feel significantly better for a month or even 2, well, it really underscores the need for patience and support. It's a journey.
Definitely a test of patience.
And one other critical point about their journey. TCAs can cross the placenta during pregnancy and can also get into breast milk. That's a very important consideration.
That leads us right into the fine print, doesn't it? Given these widespread effects, the long time course.
Yeah.
What are the big contraindications and cautions? When should these definitely not be used?
Okay, top of the list. Allergy. If someone's had a hypersensitivity reaction to any TCA, then the whole class is usually out. That's an absolute contraindication.
Makes sense. What else?
Recent myocardial infarction, a heart attack. Using TCA soon after carries a risk of causing another heart attack or making the existing damage worse. So that's a definite no-go.
Okay, heart issues are key.
Another specific one is around a procedure called myelography. It involves injecting dye near the spinal cord. You shouldn't use TCAs within 24 hours before or 48 hours after that procedure due to potential interactions with the dye.
Right.
And then the really big one, critically important, concurrent use with MAOIs, monoamine oxidase inhibitors.
Ah, yes. You hear about that interaction a lot. Why is it so dangerous?
Combining TCAs and MAOIs can trigger a severe, potentially fatal reaction. We're talking high fever, severe convulsions, hypertensive crisis, dangerously high blood pressure. It's a medical emergency.
Right.
Just don't do it unless under extremely specialized circumstances, which is very rare.
So MAOIs are basically off limits with TCAs.
Pretty much, yes. And finally, pregnancy and lactation. The risks aren't fully known, the data is limited, so they should only be used if the benefit to the mother clearly outweighs any potential risk to the baby. It's a careful calculation.
Okay, that covers the absolute don't use situations, but there are also times when you can use them, but you need to be really careful, right? Where does extra caution come in?
Absolutely. Caution is vital for anyone with pre-existing cardiovascular problems, heart disease, arrhythmias, because TCAs can stimulate the heart. That needs careful watching.
And those anticholinergic effects we talked about.
Yes, exactly. Any condition that could be worsened by blocking acetylcholine needs careful thought. Things like angle closure glaucoma, that's a serious eye pressure issue, or urinary retention, difficulty peeing, an enlarged prostate, BPH, or even if someone's recently had GI or urinary tract surgery, all need caution.
What about mental health conditions, ironically?
Good point. In patients with psychiatric conditions, there's a risk TCAs could potentially worsen psychosis or paranoia. Or in someone with bipolar disorder, it could potentially trigger a shift into a manic episode.
And isn't there a really serious warning, a boxed warning about suicide risk?
Yes, this is incredibly important. All TCAs carry a box warning, the FDA's strongest warning, about an increased risk of suicidal thinking and behavior, particularly in children, adolescents, and young adults, especially when starting treatment or changing the dose.
So what does that mean practically?
It means extreme caution, very close monitoring of these patients, especially younger ones. And often, it means limiting the amount of medication dispensed at one time, particularly if there's any concern about suicide risk. You don't want large amounts available.
That's a heavy consideration. Any other groups needing special caution?
Yes, definitely. Patients with a history of seizures, as TCAs might lower the seizure threshold, making seizures more likely. Older adults generally require more caution and often lower doses. And anyone with liver or kidney disease needs careful management.
Why liver and kidney? Because of metabolism and excretion?
Exactly. Impaired liver or kidney function can interfere with breaking down and clearing the drug, leading to potentially toxic levels building up. So lower doses and close monitoring are usually necessary there.
Wow, okay, so many things to track. Let's talk about the side effects themselves. What kind of adverse effects might someone actually experience? What are the common ones people struggle with?
It's quite a list, unfortunately, and some are definitely more common and more likely to cause problems with sticking to the medication.
Yep.
Thinking about the central nervous system, you might see sedation, feeling drowsy or tired. Sleep disturbances can happen too, oddly enough. Fatigue, difficulty concentrating, maybe weakness or tremors.
Oh, okay, so brain fog and tiredness.
Yeah, potentially. And in some cases, more serious things like hallucinations, disorientation, or ataxia that's trouble with coordination and balance.
And what about those anticholinergic effects showing up as side effects? You said they could be problematic.
Oh, absolutely. These are often the ones that patients find most bothersome. Things like a really dry mouth, constipation is very common, nausea, sometimes vomiting, maybe loss in appetite because of that dry mouth, and decreased salivation.
Okay, so GI issues.
Yeah, and urinary problems too. Difficulty starting urination or feeling like you can't fully empty your bladder, there's urinary retention or hesitancy. And unfortunately, changes in sexual function, like loss of libido, can occur.
And vision.
Yes, blurred vision is common, and photophobia, being really sensitive to light, needing sunglasses indoors, that kind of thing.
And cardiovascular effects? You mentioned caution there.
Right. While maybe less frequent than the anticholinergic stuff, these are the ones clinicians watch very closely because they can be serious. Orthostatic hypotension is a big one, feeling dizzy or faint when you stand up quickly due to a drop in blood pressure.
Ah, the head rush thing.
Exactly. But also potentially increased blood pressure, hypertension, a rapid heartbeat, tachycardia, other irregular heart rhythms, or arrhythmias. And in rare, serious cases, even myocardial infarction, angina, palpitations, or stroke have been reported.
That's a lot. It sounds like a patient could be dealing with quite a cocktail of side effects while also trying to manage their depression.
It's a huge challenge, absolutely. These effects, especially combined, can be really intolerable for some people. And unfortunately, that leads them to stop taking the medication, sometimes even if it was starting to help their underlying condition. It's a real balancing act.
And you can't just stop them suddenly either, right? You mentioned withdrawal.
Correct. Abruptly stopping TCAs can cause withdrawal syndrome. Symptoms like nausea, headache, vertigo, or dizziness, just feeling generally unwell, malaise, and sometimes vivid nightmares. It's important to taper off slowly under guidance. The good news is some side effects might lessen over time as the body adjusts, but others can persist.
Okay. Given this complex profile, it makes sense that TCAs could interact badly with other drugs. What are the really important drug interactions people need to know about?
Well, some drugs can actually increase the levels of TCAs in the body. Things like cimetidine, an old heartburn drug, fluoxetine, which is Prozac, an SSRI antidepressant, or ranitidine, another heartburn med. Combining these can boost both the good effects and the bad effects of the TCA, especially those anticholinergic problems.
So, more dry mouth, more constipation.
Potentially, yes. So if those combinations are necessary, you need close monitoring and might need to lower the TCA dose.
Okay. What about things like blood thinners or drugs affecting the heart?
Right. If you combine TCAs with oral anticoagulants blood thinners like warfarin, it can actually lead to higher levels of the anticoagulant in the blood. That significantly increases the risk of bleeding. So very frequent blood tests like INR monitoring and careful dose adjustments of the blood thinner are absolutely essential.
That sounds critical.
It is. And with drugs that affect the heart or blood pressure, like sympathomimetics, think adrenaline-like drugs, sometimes found in cold meds or clonidine, which is used for blood pressure, combining them with TCAs bumps up the risk of arrhythmias and high blood pressure. That combination is generally best avoided, especially if someone already has heart issues.
So connecting this back,
Yeah.
out of all these potential interactions, which one stands out as the absolute most critical, the one everyone needs to be hyper aware of?
Without a doubt, it's the interaction with MAOIs, monoamine oxidase inhibitors. I know we mentioned it as a contraindication, but it bears repeating because the risk is so severe.
What happens again? Serotonin syndrome?
Yes, you can get severe serotonin syndrome, or what's called a hyperpyretic crisis. This involves dangerously high fever, extreme muscle rigidity, severe convulsions, blood pressure shooting up. It can absolutely be fatal. While theoretically, there have been super rare, highly specialized situations where experts try this combo for patients unresponsive to everything else, the risk is just sky high. As a general rule, for almost everyone, combining TCAs and MAOIs is a definite avoid, full stop.
Okay, message received loud and clear on that one. This has been incredibly thorough. Let's try to bring it all together now with some practical wisdom. For someone living with TCAs or a provider guiding them, what's essential?
It really starts with a comprehensive assessment before even starting the medication. Checking for allergies, definitely. Getting a handle on liver and kidney function. Asking about those pre-existing conditions, glaucoma, BPH, the enlarged prostate, any heart problem, GI blockages, recent heart attack, or that myelography procedure.
Right.
And obviously pregnancy or lactation status, any history of seizures, other psychiatric issues, and critically, are they currently taking an MAOI? Baseline vital signs, maybe a baseline ECG to check the heart's rhythm, and those liver and kidney function tests are really important groundwork.
Okay, groundwork done. Then someone starts taking the TCA. What are the key things for their ongoing well-being and safety?
Number one, without question, is that warning about suicidality. Patients and their families need to be explicitly told about the risk of depression worsening or suicidal thoughts emerging, especially when starting or changing doses, and particularly in younger people. That conversation has to happen.
Crucial. What else?
Managing expectations about the timeline. Explaining why the initial dose is often kept the same for 4 to 8 weeks. It's to give the drug a fair chance to work before deciding it's not effective. Patience is key.
And practical safety tips.
Yes. If sedation or those anticholinergic effects like dizziness are bad, taking the dose at bedtime can help minimize the risk of falls or accidents during the day. And definitely warning patients to avoid driving or other hazardous activities if they feel sleepy or dizzy during the day.
Makes sense. What if side effects are happening but aren't necessarily emergencies?
Minor side effects might be managed by reducing the dose slightly, under guidance of course. Major or life-threatening reactions, the drug needs to be stopped immediately.
Okay. Are there simple things people can do to cope with those common annoying side effects like the dry mouth or constipation?
Absolutely. Comfort measures can make a real difference to quality of life and sticking with treatment. For constipation, setting up a regular bowel program, maybe increased fiber, fluids, scheduled toilet time can help. Taking the pill with food might ease any stomach upset.
Good tip.
For dry mouth, chewing sugarless gum or candies, or frequently sipping water can provide relief. Wearing sunglasses helps with that light sensitivity photophobia. And staying well hydrated, drinking plenty of fluids, can actually help minimize the dizziness from orthostatic hypotension.
It sounds like empowering the patient with information is really central here.
It's absolutely vital. Thorough patient teaching is key. Making sure they understand the drug's name, their specific dose, what side effects they might expect, what warning signs to look out for, like worsening mood, and these practical measures for safety and comfort.
And it's not a set it and forget it kind of medication, is it?
Not at all. Ongoing periodic monitoring and evaluation are essential. Checking how the patient is responding, asking about side effects, see if the teaching and comfort measures are actually helping, and checking if they're taking the medication as prescribed. It's a continuous process. And underlying all of this is the need for support and encouragement. Dealing with a diagnosis and managing a complex medication regimen like this can be tough. Support makes a huge difference.
What an incredibly detailed journey through tricyclic antidepressants. We've really covered a lot from their fundamental action in the brain chemistry
Yeah, that intricate balance.
to their surprisingly wide range of uses beyond depression, which I think is fascinating, and then delving into those crucial safety considerations, the interactions, the side effects.
Which are so important for people to understand.
Absolutely. And finally, the vital role of careful management, patient education, and just that ongoing support. It's clear they're complex medications requiring real care.
They really are. And, considering that intricate balance of brain chemistry we talked about and those often long timelines for TCAs to show their full effect, it makes you wonder, doesn't it? What does this journey with a medication like a TCA tell us about the kind of patience and maybe the self-awareness needed when we're managing complex health conditions? And perhaps just how much more there is still to learn about our own internal landscapes.